Thank you very much, Hein, for the introduction. Morning, everyone, and thank you for the invitation to speak about what drives recurrent atrial fibrillation in patients. This is work that I will be presenting as the outcome of 4 years of work in the Catch Me Consortium, and I'm presenting this on behalf of all our esteemed collaborators, many of whom are in the audience today. So, 2 years ago, after we last met in Nice for the 6th Consensus Conference, we published a statement summarizing the outcome of our discussions about recurrent AF. This was what we said. We noted that there's a growing realization that rhythm control interventions only target part of the relevant disease processes that drive recurrent AF. And more importantly, we noted that other conditions such as obesity, lack of exercise, hypertension, heart failure, and also sleep apnea might have associations with recurrent atrial fibrillation. Now, this statement very much aligned with our thoughts in the Catch Me Consortium, and we published these thoughts that we had in 2015, actually, in a Nature Reviews Cardiology manuscript. We were very interested in understanding the sorry, I'm missing my cursor here. Yeah, so we were very interested to explore the different drivers of recurrent atrial fibrillation, hoping that they could do two things for us: to firstly indicate the mechanisms that are involved in recurrent atrial fibrillation, and more importantly, lead to targeted or stratified approaches for preventing and also treatment of recurrent atrial fibrillation. So what we noted from these studies was that most of the observations were made in relatively modest-sized cohorts, and they have very particular inclusion or exclusion criteria, and usually looking at a limited number of covariates in those studies. Now, within the Catch Me Consortium, we were actually very fortunate to have, as a group, many existing patient data sets, and we decided to combine all this patient data at the individual patient level. We then used this combined data set that we had and undertook prognostic modeling to be able to identify the different predictors of atrial fibrillation. Now, this approach allowed us to repurpose high-quality data which had been meticulously collected over the years, and we thought that this was actually a good representation of how clinical practice actually is in real life across Europe. Now, what do I mean by individual patient data approach? Now, what we did was to harmonize data from 6 different studies, and we extracted 270 baseline and follow-up parameters in the combined cohort of 2,465 patients. Now, we recoded all this data in collaboration with the data owners, and we use a semi-automated process to achieve comparability of the latent concepts that were measured in different studies. Then we ran a Delphi survey involving 20 experts from 4 European countries by asking them the question: do you think this characteristic would be an important predictor for recurrent atrial fibrillation? And this allowed us to rank 120 potential predictors by importance, clinical importance. Now, after considering the Delphi ranking, data availability, and also sample size calculation, we applied statistical selection using a backward elimination, and this firstly fits a model of all the characteristics, then eliminates the least important characteristic until we achieve a significant model. Next, we then fitted a Cox regression model to quantify this relationship of the characteristics with recurrent atrial fibrillation. And in a subset of these patients, we actually had plasma available, and we quantified 8 common cardiac biomarkers and evaluated their added predictive value to this model. Now, I show you here the cohort that we were working with. We had 1,059 patients without and 1,406 patients with recurrence of atrial fibrillation with a median follow-up time of 233 days. Here, we note that there are some differences between these two groups in age, sex, height, left atrial diameter, history of catheter ablation, use of flecainide, as well as type of AF. Now, the take-home message here really is that this combined cohort is a good representation of patients who have had catheter ablation and also antiarrhythmic drug therapy And again, this is reflective of what is encountered in clinical practice. Now, from the Delphi process, when we surveyed the experts, this is what they told us. They told us that these are the characteristics which they thought were very important for predicting recurrent AF. And we see the usual suspects here: the age, sex, BMI, hypertension, mitral valve disease, and heart failure. After the modeling process, here was the outcome. We see, firstly, that females have less risk compared to males for experiencing recurrent atrial fibrillation. For every increase in 10 years, we see an additional 5% risk. For those who have a chronic form of AF, they are at a higher risk of recurrence. And this is the same for those with increased left atrial diameter on an echocardiography. And we see that those who have had an ablation have lower risk of recurrence. Now, perhaps you might be thinking here, these predictors are somewhat unsurprising, maybe almost expected, but I think what is interesting here is all the other characteristics which we thought were important to begin with, such as BMI, mitral valve disease, heart failure. They seem to have dropped out of the model and don't seem to predict increased risk of recurrent atrial fibrillation. And finally, we note here that there is a significant interaction between sex and age. And to describe this a bit further, here we see the hazard on the left and age in years on the x-axis. We plot here the hazard for males, and as expected, you see the risk increase with increasing age. And now we see here the hazard for females, which also increases with increasing age, but note that it surpasses the males at about 52 years of age. And from here, what we could understand is that males are at higher risk earlier in life, but females are at higher risk later in life. And we know that there's currently a lot of interest in the age-sex differences, and perhaps this interaction here might explain some of those that have been observed in the literature. Finally, here we see the biomarkers that we have quantified and their implicated pathways. I think Renata had summarized these very well earlier. The outcome of which was perhaps slightly surprising. We see that cancer antigen 125 and interleukin 6 were significantly associated with recurrent AF after being adjusted for the risk of all the other factors mentioned earlier, as well as differences between the studies. And we also question, is there an added predictive value of those biomarkers to the main model I presented earlier? And it doesn't seem to be the case. It seems that the area under the ROC curve, or the C statistic, with or without biomarkers for the model, remained somewhat, well, in this case, exactly the same. So allow me here to conclude what we have found. From our analysis in a combined cohort of 2,465 patients, majority of which were on antiarrhythmic drug therapy with a median follow-up of 233 days, we have found that patients with a higher risk of recurrence are those who are older, male, have a non-self-terminating form of AF, have not had an ablation before, and have a larger left atrial diameter. We also note here that women have a higher risk at older age from the interactions that we have found. And for our data set, it seems that cardiac biomarkers did not seem to improve risk prediction for recurrent AF. And finally, as a broad point, we have managed to develop methodologies to be able to combine and repurpose high-quality data, and we would encourage that this is something to be considered when embarking on a new study. So allow me here to end by thanking all our collaborators in the Catch Me Consortium and also the European Commission for all the support that you have given us to be able to achieve this piece of work here. Thank you.